3.
Hi, I'm Lisa Snyder. I'm here presenting my capstone presentation on early mobilization. Fact: we live most of our lives in an upright position. Humans are usually only horizontal for about 8 hours, if that, unless you're a teenager. Just because we are sick or hurt doesn't mean we can't move. Some objectives we're going to cover today: identify 4 benefits to early mobilization, identify the importance of early mobilization, identify the indications and contraindications for early mobilization of patients, identify special equipment available to assist with mobilization. Early mobilization should begin within 48 hours of admission. It's proven safe and effective treatment for prevention of long-term weaknesses and disabilities seen in hospitalized patients. 89% of the patient's time in the ICU is spent in bed rest. 1 week on bed rest can result in up to 20% muscle loss, an additional 20% loss for each subsequent week. 1 week of mechanical ventilation alters respiratory muscle strength, leads to delayed extubation and prolonged mechanical ventilation. Long words. Appropriate indications for early mobilization: ICU-induced bed rest and continuous sedatives, stability of hemodynamic status, reversal of the negative effects of prolonged bed rest. Indications for not using early mobilization: patient does not meet criteria for mobilization, the patient's unstable, proper equipment not available, proper orders not documented for PT, OT, or mobilization. And this I put up here, it's a slide to show you the barriers that we meet when we introduce programs for early mobilization, and it also goes to, it shows you the resolutions that we can use to resolve those barriers. Protocols for mobilization activity for ICU patients. Most importantly, maintain safety of the patient. Patient meets criteria for activity. No hemodynamic or respiratory compromise. The staff is trained and appropriately educated on early mobility. Orders for early mobility are noted on the patient's chart. Protocols for mobilization activity. Contraindications for early mobility: patients with cardiovascular, pulmonary, or musculoskeletal instabilities, unstable fractures, spine instabilities, use of pressors or inotropic medications to maintain hemodynamic stability. Some benefits of the early mobilization program: reduces ICU and overall hospital stay, decreases days on the ventilator, increased percentage of patients returning to a functional independence, decreased DVT rates, average cost of savings $1,300 per patient, increased percentage of patients returning home versus rehab. So some education. Sufficient education to ensure nurses feel comfortable with the task of mobilizing critically ill patients, and to ensure they know what potential side effects and or risks that could occur to the patient. Ensure orders are placed per physician and criteria applied to the patient for mobilization. Proper documentation of the event and any adverse effects mobilizing may have on the patient. IV, they pull out their IV, or they desaturate during the activity. Research has shown, studies have found that early mobilization is safe and effective within 48 hours of admission. Up to 7 days a week, at least once per day. Fewer than 1% medically detrimental events have been observed during the studies. No central lines, endotracheal tubes, dialysis catheters, chest tubes, or surgical drains have been dislodged. Only 12% therapy sessions ended early, mainly due to fatigue or patient refusal. No adverse events. So make sure you put a gown on the back of them when you get them up, or else you're going to know why they're in the ICU. Some equipment that we use: gait belts, canes, walkers, mechanical lifts, light gates, and the Sarah Plus. And these are some different pictures, kind of shows you how they're mobilizing the patients with the light gate. This is a postural control device that allows the therapist to facilitate and cue proper patterns of walking. This can allow for partial weight bearing, fall-free environment, and earlier gait training. Contraindications to the light gate would be rib fractures, herniated or ruptured disc, acute total hip replacements or hip fractures, non-weight bearing through the pelvis or hip, and any abdominal wound packs. Precautions, of course, are G-tubes, colostomies, compromised skin integrity, recent history of DVT, or halo. The Sarah Plus is a standing and raising aid, removable foot plate to allow advancement into walking, specialized slings pull hips forward rather than straight up, more upright and natural position, increased safety with transfer training. And there's the Sarah. The bottom line, early mobilization and activity are very important to the acute care trauma patient. An interdisciplinary approach is key to success. You have many resources. Any questions? I do have a short 4-question little quiz for the end of this, and I do have a survey I would like for y'all to fill out. Otherwise, thank you for attending.